Good evening, everyone. Welcome to Rehabilitation Sciences YouTube channel. We're here with the second lecture today, evidence-based approach towards lateral epicondylitis. And we have with us Dr. Parth. Dr. Parth, we would like to have your consent for making your lecture live on YouTube, sir.
Yes, sir.
Yeah, yeah.
Please.
Thank you so much, sir. Thank you so much for your consent. And moderator today, Dr. Harpreet, he'll be starting the session soon. Dr. Harpreet, you can start session, sir.
Yes, good evening and welcome to Rehabilitation Science Group. Today we have for discussion Dr. Parth Trivedi with more than 5 years of experience in the field of physiotherapy. And these 5 years are not only keeping him young, but he has received many awards of being Young Achiever Awards. And the achievements that Dr. Parth has is that he has been a peer reviewer and an academic editor for various journals and academic publications. He has 18 international publications to his name. And the qualifications of Dr. Parth include MPT in ortho and sports, and he's also a PhD scholar. Currently, he is working as a lecturer at CM Patel College of Physiotherapy in Gandhinagar, Gujarat. He is also having a postgraduate diploma in hospital administration. We welcome you, Dr. Parth, and you may please continue.
Thank you, Dr. Harpreet, sir, and Dr. Pandey, sir, for a wonderful introduction. Uh, yes, very good evening to all, and welcome to Rehabilitation Science Group for my lecture today. Uh, as it says, it is evidence-based approach towards lateral epicondylalgia. I could have termed it as tennis elbow. I could have termed it as lateral epicondylitis. I could have termed it as lateral elbow pain. Okay, but I have specifically used lateral epicondylgia. Yes, so we would be discussing why I have used lateral epicondylgia, first thing, and second thing, an evidence-based approach. So when I say it as evidence-based approach, it is still today. Okay, so people may say that we have a research which says that this is possible, this is possible. Yes, definitely everything is possible when it comes around a research. So that is why it is research. Yes, but what is the level and what is the significance of that research, and how do we term it out, and how we come it out of with that research? That is what is basic importance is. So once again, I would like to have I'll thank Rehabilitation Science Group for providing this such an enormous platform where I can put my views, and I can also accept what other people want to say in this area of interest. Okay, so before we move on with this, I would like you to go on to app.gosoapbox.com. Okay, so if you go to app.gosoapbox.com, you will have a login ID which will be asked. So if you log into that ID, into that, I'll show it into my screen again. So if you go to this app.gosoapbox.com, okay, so you'll have an access code which will be asked. So please put 477092265. So this is an access code. So click on to join now, and once you join it, you'll ask your name, and you have an set of questions which are supposed to be do. So please click on each question and put, just say it out your vote. Okay, so I'll come back to this at the end of the session. And also, if you have any queries, you put down in the comment section into our YouTube live channel. Okay, so moving on towards the lateral epicondylgia, epicondylitis, tennis elbow. Why are we so concerned about it? Yes, why are we so concerned? And what is the rate, and why do we need to think about it? Yes, people say it is just an elbow pain and it may probably go within 4 weeks, or it may probably max to max it may go into 2 to 3 months, and it may not be such a serious issue which we are talking about. But just for an information, these are the good celebrities which we know, renowned throughout the world globe. Um, at a point of time, Sachin Tendulkar was also affected by lateral epicondylgia or tennis elbow, and he thought that his career was over. Yes, so this is a serious concern. Tom Brady, yes, a player, he also had a tennis elbow and says it was injuries won't be an issue. Yes, but he is having an tennis elbow which was at a peak when he was into his career. And one of the Bollywood actress, Urvashi Dholakia, also was diagnosed with the tennis elbow because of extreme use of phone. So here they have mentioned about tennis elbow and the cause is mobile phone. So just imagine that, when you term it out tennis, people think it is just because of tennis. It is not just because of tennis, it is because of repeated injuries and micro traumas which has been caused to the lateral epicondyle muscles, origin of the muscles. We'll talk about it as we move on in our presentation. So it is one of the most commonest soft tissue injury of the elbow, and it has definitely effects on your day-to-day life. So that is why we are going to go and check it about what can be the approach towards treating these patients. Okay, so we just think that when it is a soft tissue injuries, we may provide ultrasound, and we may go with stretching and strengthening exercises, or max to max we may go with laser. And if we want to show off that we are into an extraordinary advanced practice, we may go with extracorporeal shockwave therapies, whatsoever it is. So we would be discussing each and every treatment parameter as far as what current evidence is, and it may be updated as the time passes, but what is it till today and on the hierarchical size. So probably in most of the cases, I will be talking about systematic reviews and RCTs. Where I don't have systematic reviews and RCTs, I'll be giving you, I'll be discussing about case reports or lesser evidence studies. Okay, so moving on, what will be the content flow? We'll be discussing about definitions and characteristics, basic anatomy, not in a deep matter, but a basic out through of the anatomy. Pathophysiology, yes, why we can term it as epicondylitis and why can we term it as epicondylgia. Signs and symptoms, yes. uh, Diagnosis, how quickly and how efficiently we can diagnose that. Management, and that would be purely on evidence practice. Okay, so when I talk about definition cannot be just like a lateral elbow pain which has pain which exerts on wrist extension. Yes, so definition can always be divided into your participation restrictions, into your structures which are involved, and pain component. Yes, so these are the three things which we need to divide it when we talk about definition. Why? Because we have to term it now into an format of international classification of diseases. Yes, so when I talk it about ICF, I need to bifurcate in three basic parts where the which structure is involved. Okay, secondly, what is causing pain and the participation restriction. So when I broke this three, then I can definitely incorporate that into my ICF classifications. Okay, so we will be discussing about a general term definition first, and it is not a new term. In 1873, the tennis elbow was first used by Runge. So you can see that so many years we are coming up, and we have into a max to max evidence based practice, we have a very less evidence into treating this condition. And how it has been defined? It has been defined like a pathologic condition. Yes, in a common term, if I want to explain to a patient, or if I when I'm just discussing it about, it is an epicondylitis which is defined as a pathologic conditions of wrist extensor muscles. Okay, so when we talk it about wrist extensor muscles, their origin is at a lateral epicondyle region. Yes, so a pain or difficulty over the lateral epicondyle region, which is the origin of wrist extensor muscles. Okay, that is tonus, a tennis elbow, and it is not basically because of your elbow movement. This is because of your wrist movements. Yes, so that is why it becomes more complex when you term it out for the treating purpose. And the tendinous origin of ECRB, so extensor carpi radialis brevis muscle, is the commonest muscle which is involved. When I term it out as a commonest muscle, we need to think about other muscles also. But in majority cases, ECRB is the muscle which is involved in uh, getting pain because of lateral epicondylgia. So as I said, I will be bifurcating this definition into three basic parts for a better understanding. Structure affected. Yes, why structure affected? So we all know that it is because the structure which is commonly affected is the lateral epicondyle of the humerus. Okay, so the lateral epicondyle of the humerus is the major structure which is involved, and it is a chronic overuse injury leading to the extensor tendon damage of the forearm. So these are the basic things which I'm highlighting over here. Chronic overuse injury, extensor tendons, and what happens? It happens a micro tears of extensor tendons, and additionally may affect this uh, type of compositions, neural drives, and stiffness of muscle tendon complex. So basically, it is a chronic overuse injury of extensor group of muscles which originate at lateral epicondyle of humerus. So this is the definition as for the structures which are affected. Okay, moving on to the next one is activity which is limited. So when we term it out as a pain over elbow, so majority of cases, when you have knee pain, knee movements are restricted, and it is basically because of knee which has been involved. But in lateral epicondylitis, your wrist is working and your wrist is causing pain to the lateral epicondyle region. It is not your elbow flexion or elbow extension which is causing pain in acute and subacute cases. In chronic cases, I have seen that there is a terminal range of flexion which is restricted and which causes pain over lateral epicondyle region. But in majority of the cases, because of wrist muscles, wrist actions, yes, whether it is gripping or whether it is extending your wrist or whether it is flexing your wrist, it causes pain over lateral epicondyle irrespective of other joint injuries. Yes, so in this, uh, as far as the activity is considered, it is an inability in performing excessive, quick, repeated activities, gripping and manipulating of objects using hands. So basically, activities like holding a water bottle or holding a grocery bag, yes, and you are using pronations and supination activities. These activities are probably screw fixing activities. Okay, so these kinds of activities are restricted. So what in definition, what we have learned first, what we have learned is the structures which are affected. So structures which are affected is your lateral epicondyle regions and common extensor muscles. Yes, why? Because micro tears occurs, and it is first thing, it is micro tears which is causing the problem. Second thing, what kind of activities are restricted? Activities restricted are like pronation activities, supination, wrist activities, and repeated movements and gripping activities are restricted. And what kind of participation restriction is there? Participation restriction is there because it causes, you are not able to type and you are not able to hold your grocery bags, or you're not, if you're a hardcore laborer, you're not able to fix your screws, you're not able to hold a hammer. So these kinds of participation restrictions are there, and this decreases the productivity. So that is why we are talking about and reducing the productivity, which is a major concern over this. So when we term it out, a condition which needs to be treated and which needs to be taken care of, why it needs to be taken care of, it is not just because of the pain component. It is because of activity restrictions and participation restrictions, which is a major concern in this case. And I have seen, patients who are just software engineers, and they have this pain. And recently I'm treating one of the skilled person whose work is not to do any computer work, or he's not into a hardcore laborer, but he is into a professional activities, but he is doing his exercises regularly. In that cases he's having problems. Okay, so this is why we are concerned or treating this kind of cases. So moving ahead with this, so as I said in my previous slide, that we will be discussing very brief about the anatomy. As we all know that elbow joint is a hinge type of joint. And how do we have this elbow joint? We have humerus, radius and ulna, which makes the elbow joint, and various ligaments are there: ulnar collateral ligament, radial collateral ligaments, quadrate ligaments. And commonest muscles are the biceps, which is getting inserted, and triceps, which is inserted onto the posterior part of your elbow joint. And the origins of the muscles, which is onto the lateral side, we have common extensor group of muscles. I would use the annotation. Yes, so common extensors group of muscles is onto the lateral elbow epicondyle, and common flexors is onto the medial side. So when we have medial epicondylitis, which is also known as golfer's elbow, which is less compared to the tennis elbow. Yes, why? Because of the more wrist extensor activities and the concentric work, which the concentric and eccentric work which the ECRB does compared to your flexor group of muscles. Okay, so these are the commonest muscles. The blood supply is the basic cause which leads, if you're not treating a patient into acute or subacute cases, and if it goes to chronic cases, one of the cause which the prognosis goes down, and recurrent causes are is because of your blood supply, because of decreased vascular supply. And it is basically through ulnar collateral arteries, middle collateral arteries, and radial collateral arteries, and recurrent arteries. Elbow, we have flexion and extensions, and commonest conditions are fracture, epicondylitis and arthritis. So this is an anatomy of elbow joint. Why I am discussing about anatomy of elbow joint? Because of lateral epicondyle of humerus. I am not discussing any anatomy of wrist joint, because I will discuss about its biomechanics later on in the as the presentation moves on with this. Okay, so apart from this, yes. Uh, what is the role of ECRB and ECRL? We are going to discuss in this slide. The role of ECRB and ECRL is to cause the wrist extension. Yes, so the wrist extension movement, which I'm showing it over here, it is the basic movement of ECRB, which is known as extensor carpi radialis brevis and extensor carpi radialis longus. Okay, and which causes wrist extension covered by brachioradialis muscle throughout the forearm. Okay, so you have its origins over here, lateral epicondyle. It goes to the wrist and it covers the throughout the forearm, and it is covered by brachioradialis muscle. Pure wrist extension with some aspects of radial deviation is the function of ECRB. Okay, so radial deviation is also one of the part which ECRB does. Yes. Now, this is the good picture which I want to describe it in detail. What happens? Why I have termed it out this as good, and why I have termed it out this as poor. Yes. So if you can see that I have mentioned here this as good and this as poor. Why? So whenever we talk about force generation, so force is always generated from larger group of muscles. So larger group of muscles are your back muscles and your hip muscles. Okay, so basically when a player is playing tennis, and one of the major cause of having lateral epicondylgia or lateral epicondylitis is repeated wrist extension and backhand stroke. So this is particularly a backhand stroke. Okay, so this is particularly a backhand stroke. So what are we seeing in this picture? The force or the muscle uh, is generated, muscles of the scapular group of muscles and shoulder group of muscles are generating force from here. It is traveling towards your arm, forearm, and what is happening? The ball is striking late. In this case, the ball is striking late to the racket, and with the various kind of rackets, whether the string tension is tight or whether the string tension is less. Okay, we will discuss as we move on. But if the ball is striking at this end of the racket, what happens if the elbow is flexed? The force transmission has already been, the force has already been generated from the shoulder group of muscles, but the full force is not being transmitted to the racket. Okay, so what happens? More force is required at this angle. The wrist has to transmit or has to contract more. So what is happening? Wrist flexion is happening more. Okay, and gripping is tight. So wrist flexion and gripping is tight. It is causing eccentric activity of ECRP muscles or extensor muscles. And as soon as you are supposed to do the wrist extension movement, in this case, what happens? A forceful wrist extension is occurring, so that because the force generated, which is from the shoulder group of muscles, has not been able to give a proper momentum throughout. So this momentum, to generate that force, again the wrist has to contract more so that the ball travels to the opposite court. Okay, so that is the wrist is contracting more. Okay, so that is causing sorry yes, so that is the basic reason why this and this is, now you can understand why this is the poor angle. I'm sorry, yes, so why this is, I've termed it out wrong over here. Okay, this would be poor and this would be good, sorry for that. But yes, so this is the good. Why? Because you are using the elbow muscles and you are using the wrist muscles over here, and whereas you are not using the wrist only group of muscles to generate the force. Okay, so moving on with the next group. uh yes, so pathophysiology. So pathophysiology, yes, the traditional view, what does it says? Okay, the traditional view says that because of repeated wrist extensions movement, yes, wrist extension group of movements, there is a cause of macroscopic and microscopic tears at common tendon. Okay, so common tendon, yes, is of wrist extensors are causing chronic overuse injuries. Okay, but but these leads to tear and the healing is restricted. Okay, so we are not one of the major thing which I've seen in when I see tennis elbow cases or lateral epicondylitis cases, what do patients do generally once they have pain over lateral epicondyle region? Immediate thing, they will apply ice and they will probably take non-steroidal anti-inflammatory drugs, and in worst come worst cases they will go with the corticosteroid injection so that the pain is suppressed. But when the pain is suppressed, it is when you are not correcting the biomechanics and when you are not having the healing procedure is not completed, what happens is this microscopic and macroscopic tears, they are not healed properly and they are having more amount, the collagen type 1 and type 2 are being replaced by fibroblasts. So once they are being replaced with the fibroblasts, the elasticity component of the muscle is lost, and that continues, the cycle continues of having uh, macroscopic and microscopic tears. So that is why Dr. J. Syriax in 1936 stated that as these tears attempt to unite, the healing surfaces are pulled apart with the continuous use of hand, resulting in self-perforating and chronic inflammation. So this is in 1936, J. Syriax had stated, and that is why Syriax deep friction massage was being advocated to help out and to regain the elasticity component of lateral epicondylgia cases. Okay, so that is why it is an inflammatory model for rehabilitation. So that is why we term it out as lateral epicondylitis. Okay, so we will be seeing a video, a wonderful video, which gives you us a brief idea about this. So yes, so through this video, we have come to know that, this lateral epicondyle region where my cursor is moving is the basic cause of pain. And why? Because of repeated extensions, wrist extension movements, which is causing pain over this um, lateral epicondyle region. Yes. So now sequential studies which have been later on performed post the celiac's advocacy, they say rather than an inflammation procedure, the repetitive injuries are causing the trouble, and that is causing delay in healing procedure. And in that delay in healing procedure, the fibroblast and mucopolysaccharide infiltration occurs, and that mucopolysaccharide infiltration results in decreasing the elasticity component. Yes. So in 1970s, Dr. R. Nischel stated that, dense population of fibroblasts and immature collagen. And one of the major thing in his study he has stated is that absence of inflammatory cells or inflammatory markers. So when you have no inflammatory cells and when we don't have any inflammatory markers, how can we term it out as epicondylitis? Okay, so that is why lateral epicondylitis post 1970s at many places it is now being told, it has been termed as lateral epicondylgia. It is still a controversial statement by in a study, but uh, it has been clearly told by him that it is the population of fibroblast increases irrespective in place of collagen 1 and 2 types of fibers and the immature collagen fibers. So that is why angiofibroblastic hyperplasia occurs. Hyperplasia occurs, and that is the reason where the healing procedure is delayed, and majority of the cases who are having first episode of pain, they term or they tend to have second or third episode of pain if we are not treating their biomechanics. Okay, or if we are not having a proper activity modifications. So in this cases we need to think that only and only stopping of pain or probably strengthening of the muscles is not going to help it out with us. We need to think about modifications of activity, and we also need to think about changing the biomechanics of that. Okay, so that is why the then, as I said, why it is epicondylitis? It is because of inherent simplicity. Okay, because we are listening it, we are focusing it, and as we say that it is pain over one particular region, so we term it out as an inflammation, and then it is the continuous usage of epicondylitis. So because of inherent simplicity and still lack of evidence which supports the angioplastic hyperplasia, we in majority of places it is termed as epicondylitis rather than epicondylgia. Then, as I said, what is the cause of pain? Cause of pain is not only muscles, it is biomechanical irritations, biochemical irritants. Okay, like cellular activities, tendon degenerations, lactic acid formations, chondroitin sulfates are the basic cause of pain if you consider when you don't have when you don't have inflammatory markers. So in case of when we term it out, why if we are not telling it out as lateral epicondylitis, what might be the cause of pain? The cause of pains is biochemical irritants like lactic acid and chondroitin sulfate. This is causing pain. You also have a neurogenic inflammation picture coming into as per Nischel. It is mechanical stimulations of nociceptors. Nociceptors are stimulated again and again because of overuse injuries, overuse of ECRP muscles, and that local release of neuropeptides. So they release neuropeptides, and that is called as neurogenic inflammation. So basically, when we term it out as lateral epicondylalgia, what are the causes of pain? The causes of pain is not just your biochemical irritants like lactic acids and chondroitin sulfate. It is your stimulation of nociceptors, okay, which is also causing pain. And this is why it is tendinosis, mucopolysaccharide infiltrations. Yes, this results into delayed of healing. Miniature bone formation, small bone formation is there over the lateral epicondyle region, as we see in osteoarthritis. Vascular proliferation is disturbed. Immature fibroblast replacing the collagen type 1 fibers. And what is why only ECRB is involved? ECRB is caused because of compromised blood supply, which I discussed in the anatomical part. Highly inconsistent vascular pattern, which is having by ECRB, and this leads to imbalance between vasoconstriction and vasodilations. Okay, so the abnormal vascularity structures, they are continuously been attributed by your autonomic innervations. So when this vasculature is attributed by the autonomic innervation, this leads to an inconsistent performance of vasoconstriction and vasodilation, which causes pain and which causes disturbed healing procedure of ECRB. And it is not just concentric activity of ECRB, it is the eccentric activity also which is causing pain. So because of more, so what happens when you are not having a proper force, or probably what you are, when you want to throw a ball towards the opposite course, what will happen? You'll do more wrist flexion and then a fast wrist contraction to generate that force. So to generate that force, you need to have more eccentric activity and fast and rapid concentric activity, which causes pain over lateral epicondyle region. And again, as I said, in our good and poor posture, there is limited internal rotation of the shoulder, and that is the main reason that this limited internal shoulder, once the force is not being transmitted to the shoulder joint, this wrist has to act more and generate more force, which causes pain over lateral epicondyle region. As I said, repeated wrist flexion is also one of the factors. So why does we have pain over pronation? Pronation because of the radial head movement. So here we will discuss. You have tensile load stress. Okay, wrist flexion and wrist extension occurs over the radial head. So because of that radial head movement, and in chronic cases, the pronation also has pain, and this further increases when the head of the radius anteriorly rotates around ECRB in pronation. So once, if this is pronation is happening, the head of the radius, if this is my head of the radius, it rotates anteriorly during the pronation time, and this causes pain because of tensile load which ECRB is having, and it is stretching. It is getting stretched during this anteriorly head rotation or radial head rotation in pronation, that is causing pain. Pain in pronation is not the primary complaint of the patient. It is in the chronic cases, yes, I have seen patients complaining pain and pronation, but in acute and subacute cases, pronation component is very less compared to the chronic cases. So what are the other structures which are involved? The structures which are involved are local articular ligaments. We have medial collateral ligaments and radial collateral ligaments which are involved. Common nerve injuries, nerve lesions are there at a point of time. It is cervical pain is also been one of the cause which has over lateral epicondyle region. So we need to have a differential diagnosis for that, whether it is because of the cervical pain. And in computer workers, it is seen that both your cervical pain and your lateral elbow pain, lateral tennis elbow pain, both are in together. Okay, so it becomes very much difficult to differentially diagnose whether the pain is because of cervical region or it is because of the elbow lateral epicondylgia. Yes, so that is why when I see computer workers, I generally prefer to treat both the cervical region and the lateral epicondyle region uh, for pain reliefs. Okay, so causing, as I said, involvement of cervical spine structures, causing direct somatic pain or referral pains, and secondary facilitation of pain through the nociceptive systems, central nervous systems. So this was what we were discussing, the tendinosis cycle. When I term it out as tendinosis, it goes towards epicondylgia. Okay, so yes. So what happens when you have increased demand of tendon? When you have increased demand of tendon, what happens? Either you go for an adequate repair, which is adaptation, or you have second option, which is inadequate repair. If it is an adequate repair, there are very less chances of recurrent pain. The collagen type 1 fibers will always be replaced by type 1, and then you can have a rehabilitation model assisting it. Okay, accordingly. But if you are not treating at this case, what will happen? Inadequate repair will happen, and then it will lead to tenocytes. As I said, tenocytes will be there, and reduction in collagen and matrix formations. And again, what will happen? These two things will reduce the elastical component, flexibility component of the muscle, and that will further predisposition factor to the injury. Okay, so for if we don't want this thing to go on, what are we supposed to do? We are supposed to treat this, and we are supposed to avoid these two factors. So we are supposed to have an adequate repair priorly to the if we don't want to get into this cycle of tendinosis. So if we don't want to get into the tendinosis cycle trap in chronic cases, we need to have an adequate repair, and we need to have an adequate load to the muscle and gradual load to the muscle, rather than just having, once the pain is less, just giving him a weight and asking him to do repetitions. I would prefer that we need to gradually reduce the pain. Okay, and then we need to have put gradual weight and gradual load for the adaptation to occur. Okay, so this is what the tendinosis cycle say about. So I would like to summarize the pathophysiology over here. It is basically a local tendon pathology. Yes, so which tendon is much more involved? It is ECRB, which is most commonly affected, and we have ECRL also being there, and EC extensor carpi ulnar is also in certain cases. Pain system changes. So it is a nociceptive stimulus which is causing pain, lactic acid formation causing pain, chondroitin sulfates causing pains, and micro tears which are causing pain. Motor system impairment, reduction into the grip strength, and repeated movements are the basic cause of this pathophysiology. So what have we discussed? That we have good evidence about term it out as a epicondylitis in past, and certainly in near past. Nowadays we have good studies which are coming that out, stating that it can be epicondylgia or tendinosis phenomena, uh, rather than your epicondylitis inflammatory model. What are the clinical signs and symptoms? Pain over lateral epicondyle of humerus, which is a well-known fact. Okay, so which is a well-known fact. Tenderness over lateral epicondyle region. So once you press it out, the patient feels pain over that. Okay. Decreased grip strength is also one of the sign of this. Localized swelling. is seen in certain cases. And so these are the basic complaints which we have seen in patients, and occasionally we see pain over pronation activities, and also pain in wrist flexion. In chronic cases, I have seen that wrist flexion also causes pain, okay, because of eccentric activities. And um, since I last two cases I am seeing in chronic cases, elbow flexion in terminal range also causes pain. So that is also one of the findings which I have seen in my cases. So how do we diagnose it? We have special tests which are of very good reliabilities and validity, and also through various imaging modalities. I would not be discussing about MRIs and sonography, but I will just say about our special test. This one is your Cosen's, this one is your Mills and Motley's test. So how these Cosen test occurs, you can see this Cosen test, the elbow is in mid flexion, and you are asking the patient to do wrist extension. Okay, so you are resisting this, and the patient is doing wrist extension, that is causing pain over this thumb region, which is lateral epicondyle region. So this is one of the special tests. So if this is a bit elbow flexion and you are resisting this, and you are asking the patient to do wrist extension, and which is causing pain over the lateral epicondyle, that is one of the special test. In Mills test, what is it? Is opposite, that you are doing the elbow is fully extended and you are flexing it. So this is basically the Cosen's test is basically seeing the concentric activity of the muscle, and this is seeing the eccentric activity of the muscle, whether it is causing pain. So in flexion, the eccentric activity of ECRBs and lateral group of muscles will be there. So please make sure that I've seen people testing it like this. Okay, so we need to flex it out, the fingers also. So make sure that you are flexing the fingers also. Okay, like a fist, you are asking the patient to do a fist. And the third test, very simplest and very fast test to do, is extension of your middle finger. Okay, extension of middle finger, which if you have pain, if the patient complains of the pain over the lateral epicondyle region, so that would be the positive signs of this. And in case we are not having this cases with this test as positives, we may go for ultrasound sonography, which is why I generally recommend an ultrasonography, because of easily availability, cheap compared to MRI, and very less time consuming. But in cases if we are suspecting cervical and the elbow pain component, you may go for MRI, and that may also help you. That will help you out. Meaning that will help you out in diagnosing it uh, accurately. So this is the special diagnosis. Okay. Uh, Generally, in clinical setups, we see that the reduction in the pain is the only primary outcome which we generally focus. Once the pain is reduced, we start moving on towards the strengthening component as soon as possible, and then we try to give them weights. Okay, so I would suggest that we need to have a treatment outcome measurement first while uh, we are treating any case. Okay, we generally ask the patient that what is your difficulty, what are your chief complaints. He would say that my chief complaint is pain, and because of pain I have restricted activities, or probably my function is restricted. Okay, but our treatment orientation is always towards reduction in pain rather than improving the functional outcomes. Functional outcomes we improve. I don't deny that fact that we don't improve the functional outcomes. We improve the functional outcomes, but our focus on immediate things is reduction of pain. Okay, so that reduction of pain is also there, but at the same time we need to focus on functional, regaining the functional capacity of an individual as soon as possible. Okay, so pain, we have visual analog scale, numerical pain rating scale, and pain questionnaire. You have pain McGill pain questionnaires, various kinds of questionnaires are there to rate it out. So I generally prefer numerical pain rating scale, because you have a value which we can quote it out later in your assessment also, and you can see it out in the prognosis part also. So numerical pain rating scale is a valid tool in checking out about pain. Hand grip strength, dynamometers, hand dynamometers. We'll be seeing the picture in the next slide. That is also supposed to be documented, because sometimes I have seen that, the patient is having pain component there. Patient says that, I am having 6 to 7 pain, complain of pain on numerical pain rating scale, but the hand grip strength is very lessly effective. Okay, and vice versa is also there. Pain is there around somewhere around 3 to 4, and the hand grip strength is very less compared to the normal side. Okay, so this needs to be validated when we talk about assessment and outcome measurement. Functional performance, the patient rated tennis elbow evaluation. Okay, a very well documented scale. If time permits, I would be showing the scale at the end of the presentation. Patient rated tennis elbow evaluation. I have personally translated this patient rated tennis elbow evaluation into Gujarati language. Okay, it has good cross-cultural validity and reliability, which not only focuses on pain, but it also focuses up on functional outcomes. And in that functional outcomes too, it is divided into two, into day-to-day functional outcomes and work pattern outcomes. So it has that if you are carrying a grocery bag, what is your kind of pain? If you're wearing a pant, what is the kind of pain? Okay, if you are typing, what is the kind of pain? So in that you get functional outcome. So I would suggest that whenever we are seeing a soft tissue related injuries or any ortho kind of cases, we just not need to focus on pain, we need to focus on functional outcomes. And for functional outcomes we need to have a dynamometer in this case, and functional performance, and DAS, dash scale, dynamic arm shoulder hand. If you are not comfortable with PRT, you can go with dash scale. So these are the basic outcome measurements which are commonly accepted. And in advanced cases, surface EMG is preferred. At the end of this presentation, I would see how we have incorporated surface EMG into a biofeedback in treating a case of lateral epicondylalgia. So this surface EMG gives you a valid numerical data, quantitative data of the muscle activity. Okay, and you get into microwatts. So what is the kind of muscle activity which ECRB is having, whether in the wrist extension and wrist flexion, onto the affected side and onto the non-affected side, so that at the end, when you are seeing the outcome and the prognosis of the case, you document it and you come to know that, whether your treatment has given you a positive outcome, or if it has just reduced the pain, but the hand grip strength is not increased, or functional performance is not increased, or the muscle activity is not increased, what can be done? And if these three has increased but the pain has not increased, what might be the other cause? So these are the things as treatment outcome. This is what I was talking about, the hand dynamometer, generally the third position, and sitting upright and without an arm support chair, and your shoulder adducted, elbow flexed to the 90 degrees, and holding it like this and gripping it for 3 times, and best average of 3 is taken in this cases. This is according to American Society of Hand Therapists, ASHT. This is the generalized pattern for evaluating the hand grip strength in lateral epicondylitis patient, and it is generally taken and a validated tool in pound. We can have it in kgs also, but universal accepted readings are in pound. So yes, differential diagnosis, which we were discussing, lateral epicondylitis in commonest is the cervical radiculopathy and intra-articular pathology, whether it is generalized. But in the cases intra-articular pathology and cervical radiculopathy, how do we differentiate it? Cervical radiculopathy, the pain is not just limited to, in majority of the cases, it is not just limited to your lateral epicondyle region. It has a referred pain and it travels from your neck, shoulder, and to the elbow, and you have restricted cervical region movements, pain also. And whereas in lateral epicondyle region, you have point tenderness, okay, and pain increases with the use, okay. And neurological findings are not as such positives if you talk about EMG and NCV, but in cervical radiculopathy we see this. And in radial tunnel syndrome also, uh, vague and diffuse pain is there, whereas in this a well localized pain is there. So it is very easily diagnostically differentially diagnosed. The only concern is in computer workers, it is difficult to diagnose with cervical radiculopathy and differentiate between lateral epicondyle region and cervical radiculopathy. So yes, now I will be talking it on towards an evidence-based management. Evidence-based management, we will be talking about non-steroidal anti-inflammatory drugs. We'll be talking about corticosteroid injections. Why I have put on this in this sequence? Because this is the commonest line of management. Okay, commonest line of management which I have seen, and we noticed it around since these past years. Okay, so topical glyceryl trinitrate, exercise therapy, stretching, strengthening, and plyometric exercises, manual therapy, including your deep friction massages, Mulligan therapy, soft tissue releases like myofascial release and MET, taping, ultrasound therapy, extracorporeal shockwave therapy, laser therapy, orthotics in terms of your tennis elbow braces, acupuncture, platelet-rich plasma injections. These platelet-rich plasma injections are in trend nowadays. Uh, uh, it would not be good to term it out on this platform, but I have seen cases who are not being uh, conventionally treated. They are immediately switched over to either corticosteroid injections or platelet-rich plasma injections. Okay, so we'll be seeing it, their efficacies, how the evidence says about it. I have not included any dry needlings or cupping therapy kind of things because they actually don't have any evidence, and they have poor evidence in terms when we talk about a good research. So that is why I have not included this. And the last one is hyaluron gel injections or botulinum toxin injections, which are also been given in certain cases. And obviously surgery. So what kind of surgeries can be done? So we'll be focusing on non-steroidal anti-inflammatory drugs. Okay, so when we don't have anti-inflammatory model, why are we giving this um, drugs? Okay, so it is still controversial, but yes, it reduces pain. Yes, definitely it reduces pain, but the evidence and clinical practice says that if you are not correcting it, if you are not putting load onto the muscle, it will have a recurrency will be seen. So pain is reduced drastically, it will come down, but the recurrence rate will increase because it is having no long-term efficacy. Again, we all know the side effects. It has GIT bleeding, gastrointestinal bleeding, and renal complications are there. So it is good to avoid NSAIDs. Theoretical risk, impaired tendon healing because inflammation is necessary for granulation tissue and collagen growth and tendon repair. So if you subside the inflammation component, you are not allowing it to have a proper tendon repair. So this is a theoretical risk, but the majority, once the pain is reduced, people will start moving on towards their activities, and they will do the same activities as they were doing previously, and then the recurrency rate will increase. Second thing, which is like, what does the research says, that topical NSAIDs have been claimed to beneficial for pain relief in small studies lasting up to 4 weeks. Okay, so in very small group of studies, it has said that up to 4 weeks, like for a month period of time, topical NSAIDs, like you have diclofenac gels and aceclofenac gels coming into the market. Even we have good sprays which has significant pain reduction. Second, corticosteroid injections. a trend, a common practice in lateral epicondylgia, lateral epicondylitis, plantar fasciitis. Okay, so these two things, and in one occasionally, or in what we say not less compared to these two things, is supraspinous tendinitis. In these three commonest soft tissue injuries, corticosteroid injections, when patient complains of pain for more than 3 months, okay, the first thing will be corticosteroid injections. Okay, this is what a trend is there, but we'll see what is its efficacy. Very short term pain relief. Okay, I've seen patients coming with the same pain or increased in pain in not less than 3 months. Okay, so once again, if pain is there, once again another corticosteroid shot, and 6 months, and again it goes on. So I would not advocate to go with this corticosteroid high recurrence rate. This is not me who is saying, it is the evidence which says, and it is reported that 72% of patients treated with steroid injections experience a recurrence rate in 12 months, compared with 9% those who have wait and see strategies, like wait and see for like you have conservative approach, or you have braces, tapings, like these things. So in corticosteroid injections, if we have a lay person also seeing our YouTube channel, please, please, please don't prefer these injections, because not because of pain relief, it is because of high recurrence rate. Topical glyceryl trinitrate, it is helpful in stimulating tendon healings. Generally, the side effects are headache, dizziness, and skin irritation. A very less studies advocates the use of topical glyceryl trinitrate. In 2011, McCallum et al. Had a study on 58 patients which were treated for 6 months with topical GTN and a placebo with a rehabilitation program. But 5 years after discontinuation of therapy, there was no difference in terms of pain and grip strength. Yes, so just imagine that GTN was been given to 58 patients, but after 5 years, again there was no difference in terms of pain and grip strength. And then why we need to go with topical GTN? Okay, why need to take that side effects into risk? Okay, and it is also documented that GTN do not offer additional long-term benefits. Exercise therapy, why? Tendon remodeling, yes, your stretching and strengthening helps out in the strengthen remodeling. Okay, tendon stress and tensile curves. Okay, muscular adaptive responses. Okay, so you have so if you have a proper exercise regimen for the patient, what will happen? That patient will have a good muscular adaptation response towards your wrist flexion and wrist extension. Isokinetic, isometric, isotonic, and plyometric exercises. So isokinetic, as we all know, the speed; isometric, the length; and isotonic, the tone of the muscle remains same. And plyometric exercises are repeated, short movement, stress-induced, very fast exercises. So what are these roles? And a meta-analysis showed that stretching plus strengthening exercises gives a better result than ultrasound plus friction massage alone. So if we just have ultrasound and friction massage giving it to the patient, but we are not giving any stretching and strengthening exercises, that will not help it out. So we need to have stretching and strengthening exercises. So it is very important. Manual therapy. In manual therapy, we have your soft tissue release therapies and therapies like Mulligan, Maitland mobilizations. Deep friction mobilization, analgesic effect is through your pain inhibitory mechanisms, descending pain mechanisms, your lateral spinal column tract, and as I said, fibroblast activities are being reduced. And Cochrane library review says that deep transfer friction massage or deep friction massages combined with other physiotherapy modalities was no better than physiotherapy alone for pain control movement of grip strength, improvement and functionalities. So, sorry. So you don't have much efficacy, okay, of deep transfer friction massage when you term it out with other physiotherapy modalities. Okay, a most recent review says that on which is based on four randomized RCTs, they have found that Mulligan's mobilization with movement, okay, movement with mobilization proves a better outcome, okay, compared to your deep transfer friction massages and pain-free grip strength over the short and long term when compared to placebo and treatments like ultrasound with exercises. So Mulligan's in one of my study also, when we had compared with Mulligan and deep transfer friction massage, we had a better outcome in Mulligan's mobilization compared to the deep transfer friction and stretching strengthening alone, which was a conventional protocol. MFR, which focuses on reducing the soft tissues. Okay, what do we do generally? We give low load and long duration stretches, and MFR is not just only onto the lateral epicondyle, it is all towards your forearm and towards your wrist retinaculum. So what we generally do is we release it from the lateral epicondyle region, and we keep on releasing throughout the forearm, and we spread it to the wrist retinaculum, extensor retinaculums. So why it is helpful? It is helpful in facial tissues lubricating quality, tissues mobility, and normal joint functionings. Okay. And Azim Shah et al. 2012 did an RCT, which is again an effective. I know I am terminated down around an 8 years old study. We are in 2020, but this was one of the best RCT available compare in terms of MFR. Okay, and this study is done on computer workers. Okay, muscle energy techniques is again a soft tissue release techniques and soft tissue pain-free mobilization techniques. You have two basic things in muscle energy technique. One is reciprocal inhibition. Okay, so in that technique, MET restores the shortened structures and tight structures. Okay, so you have agonist and antagonist muscles activations and contractions, which helps in restoring the length of the muscle. Yes, so post isometric relaxation and reciprocal inhibition techniques, they have good amount of evidence in support of this treatment towards lateral epicondylgia, and why it removes the nociceptive stimulus and it helps in restoring the normal blood circulation and thereby reducing the pain and improving the pain-free range of motion. 2013 semicuxal, an RCT which is effective. Again, taping role is controversial. We don't have a strong evidence to support the role of taping, but clinically, kinesiotaping is used where the radial head movements and the inhibitory technique of taping inhibition of ECRB muscle is done and patients are improving. So if we have a scope of doing an RCT in this, it would be great. Ultrasound therapy, one of the most commonest and first line of management as far as physical therapy is considered. I've asked the same question in our GoSop box review. Is what do you think, that ultrasound is effective or not? Yes, in acute and initial phases, it has clinical benefits. Okay, but again, the evidence says that Lundenberg et al. Reported that compared to placebo, the pain of LE patient was better 3 months after such, but there was no difference in global improvement. Okay, so it is helpful in acute and initial phases, but once the patient goes into subacute or chronic cases, the efficacy of ultrasound reduces, and it not helps us to avoid the recurrence rate. Okay, to avoid the recurrence rate. Extracorporeal shockwave therapy, it was used in calcified deposit, to destroy the calcified deposits into the tendons and various places. But what happens that micro trauma from repeated shock waves to the affected area creates neovascularization. So what happens that small vascular structures develop, and that promotes the tissue healing. So that was the mechanism. So because of micro trauma of extracorporeal shock waves, neovascularization happens, and this promotes the tissue healing. And US Food and Drug Administration has approved this treatment for plantar fasciitis and LE only. Okay, so not for any other conditions. So it has good amounts of RCTs to support. Okay, but again the cost effectiveness comes into picture. So that is why it is not much more seen into clinical practice. And another thing is that in Hong Kong, a randomized controlled trial of 72 patients failed to demonstrate. Okay, so I'm giving a contradictory statement that extracorporeal shockwave therapy was failed to demonstrate a good result compared to placebo. But we can have still more studies and systematic reviews to see whether this study, whether this modality is actually beneficial or not. Laser therapy, if the ultrasound therapy doesn't work, we have a trend of switching the patient into the laser with those fancy goggles and the scanning or probe modes. Okay, so only 904 nanometer wavelength. Okay, so 904 nanometer wavelength of laser is having its efficacy, and that too short-term pain relief. Okay, short-term pain relief is seen in these cases with the probe and grid methods rather than the scanning methods of the laser. Orthotics, generally made up of neoprene, a stretchable material. You can see various companies like Visco, Flamingo, and Tynor are into the markets for this orthotics. Jensen et al. Compared an off-the-shelf orthotic with steroid injections and concluded that both were similarly effective in early management. So you can see that we should avoid the steroid injections when we have so much of treatment option available with us. So orthotics are generally preferred because they are easily available. They are again cost effective. And why, if in terms of if I talk in terms of taping, skin irritability is seen into the cases, and tapes need to be replaced, not every day, then even on alternate days also. So rather than this, if we have an orthotics like elbow braces, they are, and even the patient feels comfortable in that. Okay, because tapes can, but the advantage of tape over is that the same duration of biomechanical correction is long duration of biomechanical correction is seen in those cases compared to the orthotics. But in Cochrane, due to limited number of trials, few outcome measures, limited long-term results, there is no definite conclusion on their effectiveness. Okay, so again, but it is advocated in clinical practice because that inhibits the ECRB muscle action. Okay, because if we tell the patient not to do excessive wrist flexion or excessive wrist extension, and they might do that work, and if the braces there, it reduces, it acts like a counter force and helping it out those patients. Okay, acupuncture, again, as I said, it is similar to your dry needlings and cupping therapies, very less and not reliable evidences are available. But Fink et al. Found that reduction in pain compared to placebo only occurred early after treatment, but there was no difference after 2 months. Okay, so if somebody is aware about acupuncture, I would say that a physical therapist should not go with acupuncture. Acupuncture should be given by the person who is known, is having hands-on training with the acupuncture. So let that person do, if at all if there is, but a good amount of evidence is required. Platelet-rich plasma injections are one of the commonest trend, and having good results. Yes, giving good results in chronic cases. The PRP injections are rich in platelet-derived growth factors, okay, which are attractive, chemoattractive to the white blood cells and mesenchymal stem cells, helps in tissue healing. Okay, that increases the type 1 collagen, which is much more important. As I said, that fibroblast, okay, fibroblast accumulation is there, mucopolysaccharide infiltration is there. So platelet rich plasma injections, when injected, they increases type 1 collagen fibers, thus tissue remodeling occurs very good. And RCT, which has compared with PRP injections and corticosteroids, reported superior for rates and pain scores after PRP. Okay, so again, corticosteroids are not advocated. A less common is hyaluron gel injections or botulinum toxin injections. Very less common, and very less physicians prefer this. Why? Because they are used in arthritis. So this again works on the pain inflammatory model, tendon healing, and it is not as much effective. So I didn't found any article RCTs for these two things. I just found an article which states this, so I have mentioned this. Surgeries, we have two types: open surgery and minimal invasive surgeries. And it is estimated that about 4 to 11% ultimately undergo surgery. So just imagine 11%, which is 4 to 11%. It is a high ratio of patients going on. If we have 100 patients, okay, so in 100 patients, so somewhere around 8 to 10 patients will go for surgery annually. So it is a huge number when we talk about the surgical waste. Okay, but sorry, extensor release with intra-articular modifications or extensor fasciotomy is generally preferred. BY slide of common extensor tendons. Renovation of lateral epicondyle is preferred. I would not be the right person to, I can just throw a light on the procedures. I would not be the right person to comment or show you the surgical procedures about this. The best person is a surgeon to discuss about this. Epicondyle resections with enconius muscle transfer, the Garden procedure with lengthening of ECR, and minimal invasive surgeries. So it has said that surgical treatment as having insufficient evidence to support or refute its use, but yes, 11% of people do end up 4 to 11% end up in the surgery. Yes, activity modification. This is from Clinical Orthopedics Broadsman book. This is a best picture, which I follow from my graduation days. How to ask if a patient is a racket player, whether it is badminton or tennis. Okay, how to calculate or how to have the grip strength of the racket. It is through this inertial technique. So this inertial technique says that what we need to have this palmar crease and this crease. So it says that proper handling of the size of the racket is from the proximal palmar crease to the ring finger uh, crease. Okay, so so what is this? If this is the length, so this size of the length should be the racket utni size ka hona chahiye. Okay, so natural technique for proper hand size is from proximal palmar crease to the tip of these, okay, the crease. So this is why the racket, and it says that somewhere around 4 to 4.5 inches is the commonest uh, racket handle size. 4.5 inches commonest racket size. So yeah, this should be uh, given, and this should be taken care in every athletic population who is having the badminton racket sports. Okay, so whether it is badminton or tennis. Okay, yes. uh, Before going to the conclusion, I would like to show you one of the video. Yes. So this is one of the video which we have just documented, and the case is published in Indian Journal of Public Health and Research this June itself, a Scopus Index journal. We would see what we have done in this case. This is through the rehabilitation. The conventional rehabilitation was you know, replaced by a surface EMG biofeedback. So these two are the biofeedback surface EMG electrodes, one on the lateral epicondyle region and another on the forearm group of muscle. So we'll see how does this works. And it had a good outcome, but long, huge number of studies, number patient studies are required to see whether it is effective or not. So the red one is the channel one. The green one, because of the background noise, we are seeing the artifacts into the channel, but even in the red, we had a bit amount of artifacts, and because of the surface electrodes, which was not avoidable. So the moving is because the patient is doing wrist extensions over here. So, sorry. Yes. So here we have on this machine we have four types of game. One is bunny game, another is plain, another is rose and pattern games. So we had select just for as the patient was inclined towards bunny game, we have selected bunny games. Else you can select any one of this. So we'll be setting about this upper and lower limit, and yes, so once it is worked, the patient is supposed to extend the wrist till that. So what I have done is 70 is the lower limit, 80 is the upper limit of the microvolts. And if the patient contracts between this 70 to 80 microvolts, then and then the bunny will go up. Okay. So in rest there is no. So work. So as we move on, that the patient has completed the 9 attempts out of 10 in what much time. So we still in this machine we still have an option of stimulating the machine. NMES is also there. So that is the advantage. And coming on towards the conclusion, that it is the common condition. LE is a common condition, uh, which is a challenging condition to treat, and especially the management. Okay, the management diagnosis is very simple. You just need to focus on your special test and differential diagnose with the cervical region. Various non-surgical modalities are there with us, and we need to select a proper in combination modality, and it depends upon the experience of the people and patient choice. In general, treatment can begin with education, correcting the biomechanics, application of commonly available treatments, and steroid injections are not at all recommended because of its no long-term benefits, and relapse rate is high. Generally, when conservative treatment fails, we need to focus on PRP injections if they have good amount of recent evidences, but it is cost effectiveness is also there compared to your steroid injections. And surgery is usually indicated for resistance patients who are not responding to the non-surgical therapy. Uh, I've seen patients, they are moving on with the they immediately switch over to the surgical or corticosteroid injections because they cannot resist the they cannot they cannot bear the pain for somewhere around 2 to 3 months. So I would not uh, utterly I'll say that I will not at all recommend steroid injections at any cost when the conservative management is not supportive, or it is not yielding out with a good positive outcome. You may go with plasma PRP injections and later on with the surgery. So thank you once again. I'll thank the Rehabilitation Science Group for inviting me for speaking on this evidence-based approach towards lateral epicondylalgia. I am here to share my experiences. I'm also here to learn from the group of people. Thank you.
Thank you, Dr. Parth, for enlightening us with the evidence-based practice for the lateral epicondylalgia. Definitely, we would find it out. It is easy to diagnose, but difficult to treat. So I would say everybody, we should go for the exact diagnosis, because a lot of condition could be, because it's a blanket term is there sometimes, the tennis elbow. And what I find it out, the tennis was invented before the invention of the tennis elbow. The
Yes.
tennis elbow has come first, then before your tennis has been come, long tennis has come in the
Yes.
world. So same thing is there. We physiotherapists should follow all the evidence-based protocol. We should focus on to the good diagnosis, and then we should choose the exact evidence-based practice what we could do for the patient. As you have covered all the area of the medical and the surgical and the physiotherapeutic system, so there is nothing has left to be asked, or there is no question at all. Thank you at all. Thank you, Dr. Parth, for sharing at this time. Thank you,
Thank
Dr.
you,
Parth.
Agrawal sir. Thank you very much. Thank you, Dharam Pandey sir, and thank you, Dr. Harpit sir, for having such a wonderful discussion on this topic.
Thank you, Dr. Parth. Thank you.